Dr. Rupal, and again, who's the Group Medical Director for Center for Sight Group of Hospitals based at Baroda, and a huge experience in refractive surgery. And she's going to be telling us how I plan PTK in different situations. On to you, Rupal.
Thank you, Chitra. Thanks for the invitation and thank you for holding such a great seminar. I'm going to be talking to everybody about phototherapeutic keratectomy, my 2 cents. It's the unique application of excimer laser for non-refractive purposes, and everybody who is doing refractive surgery should know this particular fantastic modality of treatment. The objectives of PTK are for removal or treatment of diseased corneal tissue in order to improve best-corrected visual acuity, in order to alleviate visual symptoms such as monoocular diplopia, starburst, glare. Sometimes it's done for alleviation of non-visual symptoms such as pain, foreign body, or gritty sensation. And sometimes it's done simply to improve the cosmetic appearance of the eye. The rationale is that from the very beginning of the use of ophthalmic excimer laser, its clinical potential for removal of diseased corneal tissue was recognized. And it's because cornea has lamellar structure, it lends itself very well to the excision of diseased superficial tissue, leaving really a healthy cornea behind. Manual keratectomy is often unsatisfactory for all except the most superficial lesions because it can lead to scarring and opacities. Alternative is to include lamellar or penetrating keratoplasty. So if you need to compare PTK procedures with keratoplasty, it is simpler, faster, allows faster visual recovery, and does not have the risk of tissue rejection. Also, it saves this very valuable donor corneal tissue for more severe or intractable conditions. But the procedure is limited only to anterior cornea, and it also does not preclude future LK or PK, which is a big advantage. Excimer laser properties of removal of tissue with cornea, of the cornea layer by layer with great precision is what is making use in the PTK procedure. It does not cause any collateral damage due to the unaffected tissue, except because of the limitation of the beam profile. And reepithelialization is really accelerated following excimer laser therapy. Also, it leaves behind absolutely smooth surface. It allows combination of refractive surgery along with removal of superficial corneal pathology, and has some kind of sterilizing properties, sometimes somehow involving denaturation of microorganisms. And therefore, there are a number of ways in which a PTK procedure can be applied to different disease conditions. The disadvantage of excimer laser is that inevitably, removal of anterior corneal tissue leads to a hyperopic shift. And if you don't use proper techniques, it can lead to, again, a great amount of anisometropia with no use of that vision gained. And therefore, you need to learn this procedure of smoothing, which I'll just delve into a little bit in a short while. And there are differential ablation rates for normal tissue and scar tissue, which could lead to unpleasant surgical surprises. And this also needs to be taken into account. There are different ways of classification of the PTK procedures. I will not go much into the detail for the want of time, but indications include recurrent corneal erosions, persistent epithelial defects following chemical injuries, and superficial dystrophies like map dot dystrophy. And it really depends on the proper and smooth removal of tissue, along with rapid reepithelialization. We have found that sometimes recurrent erosions can be very difficult to treat. And this is one such case of intractable recurrent erosion. This person had repeated recurrent erosions, and this is 2 years post, where after the PTK procedure, where there was no erosion repetition at all. Here what you do is remove the diseased epithelial tissue and use your excimer laser on PTK mode in order to remove the diseased basement membrane. Also then take the excimer laser on a short mode and bombard the healthy epithelial tissue in the just beyond the denuded area, so that it acts as like an anterior stromal puncture. And then put a bandage contact lens, and you'll find that the recurrent erosions are gone forever. And I have now the longest follow-up of 25 years. So if you have to use it to remove diseased tissue, you have to be very careful, because there are practical challenges. There are areas of thinness exactly where the scars are, and they are not very easy to visualize under the laser microscope. And also it's difficult to monitor the endpoint. So you have to interrupt the treatment in order to get the correct outcome. And you should prevent hyperopic shifts and irregular astigmatism. So you need to smoothen out the scars. So basic tip is that you should choose cases where the dystrophy or scarring is within the first 100 microns of the cornea. The more anterior the problem, the better are the results. And most important is to use this correct technique. When you have a scar tissue, you'll have such irregularities in the cornea. Simply passing the excimer laser would actually mimic these same irregularities at a lower depth. But if you cover it with some solution, depending upon the irregularity, you can use right from balanced salt solution to sodium hyaluronate. And then you would find that the excimer laser first goes through the fluid. And as it keeps going, making more and more passes, the projecting irregularities along with the fluid starts getting ablated. Ultimately, when you go deep enough, you would have a very smooth surface remaining, and the scar also goes away. This is one such example of dystrophy where 2 weeks post PTK, you can have results like this. The uncorrected vision went from 624 to, and the best corrected vision was 69 with plus 2.5 diopters. OCT comparison, you can make out that the scar, the tissue has become, cornea has become clear. This is another such case where you can see how nice and fresh looking the cornea is after the PTK procedure. PTKs are also used for removal of pathological tissues, where there are scar tissues in anterior stroma, pterygium, tumors, and melanoma, bad-shaped corneal keratopathy, and so on and so forth. You have to remember that limitation of the depth of involvement which can be treated is only to the superficial 100 microns or so. You have to remember that the most areas around the scar are quite thin, so there are high risk of perforation. High hyperopic shifts if you're going to go very deep. And in case the thickness of the scar is more than 100 microns, then penetrating keratoplasty is definitely a better option. And so there are a number of such indications. One very good indication is to prevent recurrence in cases of pterygium, along with removal of the scar tissue, which is invariably left behind if you have recurrent pterygiums which go to different levels in the cornea. This is one such example, and you can see there is no other way that you can get such bright and normal looking cornea after such a recurrent pterygium, and pterygium to this extent. These are the surgical steps to remove the pterygium, smoothen out the bed, allow reepithelialization, and you would find that you have a cornea without a scar. As regards removal of tumor, it helps to precisely remove the tumor. This is one example of conjunctival SCC, squamous cell carcinoma, and you also can prevent recurrence by doing such a procedure to a great extent. As regards band-shaped keratopathy, it again works very well because it's a superficial lesion. They may come back, but at least it gives a very good period of a good vision. Dense corneal plaques like this can be removed very easily. And you can also use PTK for correction of iatrogenically induced problems, where you have decentered ablations, where you have smaller zones, and which can lead to a lot of visual symptoms. You can use PTK in order to, in a way where you can increase the zone size and also smoothen out whatever are the irregularities. This is one such topo-guided treatment example. And I thank you all for your kind attention.
Thanks, Rupal. You really extensively covered it all, and I think the only thing you may not have included is even in when you're doing cross-linking, you could even do a PTK and then go ahead and cross-link after measuring thickness. And I think that was the simplest of the ones. Wonderful.